Assalamu alaikum. Hello, everybody, and thank you for joining us in the PHC for UHC webinar. My name is Hassan Salah, Primary Health Care Regional Advisor and Team Lead for Access to Health Service in the WHO Eastern Mediterranean Regional Office. And I'm the moderator for our webinar today. Let us start first with a short video on the Regional Health Alliance. Karim, the video, please.
We have 10 years to achieve the Sustainable Development Goals to build a healthier, more peaceful, and resilient world. The clock is ticking.
We have 10 years to achieve SDG 3 that ensures healthy lives and promotes well-being for all at all ages.
We have 10 years to end hunger. We can only do this if we work together.
We have 10 years to achieve gender equality and empower all women and girls across the world.
We have 10 years to ensure that everyone has access to safe drinking water and to achieve all health-related goals.
Through the Global Action Plan, we are aligning our efforts to support countries achieve our regional goals and to ensure equity so that no one is left behind.
The Regional Health Alliance builds on this collaborative platform to protect the right to health for all, including migrants and their host communities.
Together, we will leverage resources, knowledge, expertise, and partnerships. Every minute, every action counts.
Together, we will advance open science with and for communities while promoting ethical principles.
Together, we will advocate for health care services for refugees, internally displaced, and stateless persons.
Together, we will share knowledge, best practices, and pilot and scale up innovation to improve the lives of everyone everywhere. The clock is ticking.
Together, we'll do everything we can to give every child the best and healthiest possible start in life.
The Regional Health Alliance will be a platform for stronger collaboration and better health.
Together.
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 Together, we can achieve our vision, health for all by all.
Thank you, Karim. Thank you very much. Our webinar today is a brief of the 2020 achievements of the Regional Joint Work Plan for the Eastern Mediterranean region for the GAP Accelerator 1 about primary health care. And we are going to focus on 5 main topics. The first topic is dealing with the Primary Healthcare Measurement Improvement Initiative, followed with the online training course for the primary healthcare physician about the COVID-19. Third topic is the Regional Professional Diploma in Family Medicine, followed with Universal Health Coverage Priority Benefit Package. And the last topic for our webinar today is about the private health sector and its role in universal health coverage. Each topic will have a short PowerPoint presentation with around a 60-second infographic or video. We will have 2 slots for the questions and answers. Please share your question on Slido. Before I will give the floor to our colleague, Dr. Awad Mataraya, Director of the Universal Health System, for his opening remarks, I would like to thank our partners in Primary Healthcare Accelerator 1, our colleagues from Bill and Melinda Gates Foundation, USAID, UNICEF, UNFPA, UNAIDS, UNHCR, our colleagues from WONCA. Without your full support, we wouldn't be able to achieve our 2020 targets. On behalf of Access to Health Service, thank you again for you. Over to you, Dr. Awad.
Thank you very much. Thank you very much, Dr. Salah. It's really a great pleasure to be with you all today to mark the Universal Health Coverage Day, discussing a very important agenda, which is primary health care. So during this week, we are marking the Universal Health Coverage Day, which the world celebrates on December 12th every year. And the theme for Universal Health Coverage Day that was selected for this year is Health for All, Protect Everyone, in order to build on the very severe consequences of the current pandemic that the world and our region is passing through. I mean, universal health coverage is a very important agenda. It has become a political agenda globally as part of the Sustainable Development Goals. And in our region in particular, with the endorsement of the Salalah Declaration in 2018, and also the signatory of the UHC Global Compact 2023. So all our countries in the region are very much committed to move towards universal health coverage. However, there are a lot of discussions ongoing on how to achieve that agenda of universal health coverage. And we believe that it is only through a focus on primary health care, through operationalizing the primary health care approaches, that we will be able to progress towards universal health coverage. So here I would really like to acknowledge the leadership of Dr. Hassan Salah and the team who are working on promoting primary health care to become really and effectively implemented in our countries of the region to advance the agenda of universal health coverage. Of course, primary health care since more than 40 years has been a very important agenda for many countries. But the recent declaration of Astana in 2018 has really operationalized this notion of primary health care through different commitments that we hope that will be progressing on. So looking very much to the achievement that was made by the regional office and by our partners, I very much appreciated the reference to the together in the video that we have listened to, because it is only by working together that we will be able to progress on such important and such a multifaceted agenda, which is primary healthcare. With this, I wish you all the best and looking forward to listening to the different achievements that will be shared with us during this webinar. Thank you. Back to you, Dr. Salah.
Thanks a lot, Dr. Awad. Thank you very much. As we all know, universal health coverage is about access to the needed health service in a good quality and with financial protection. In the 2019 Service Coverage Index for our region, for the Eastern Mediterranean region, it is estimated at around 58, which is less than the global average of the 66, and behind many other WHO regions. In addition to this very high direct out of pocket. Definitely with the current pandemic for the 2020 Service Coverage Index is going to be less. When the pandemic hit the region in its first wave, the focus of the attention to the health system response emphasized mainly about the hospital setting and ignored completely the major role for the primary health care to deal with the pandemic. In the WHO guidance note on the role of the primary health care in COVID-19, we identified the four main functions for the primary health care in relation to the pandemic. To support the member states to identify these four functions, we developed the online training for the primary health care physicians. Dr. Tomomi will give us more detail about this topic. In the early stage of the pandemic, number of the governments actually they announced that COVID-19 is a responsibility of the public sector facilities only. This didn't continue. In a couple of months after that, these countries actually, and to increase the capacity for the service delivery, they allowed the private health sector to test, to trace, and to treat the COVID-19 patient. Our region has 79,000 public primary health care facilities with the optimal quality standards, and to reach to the universal health coverage by the year of the 2030. No way that this number of the public primary health care facilities alone can provide universal health coverage to around 0.6 billion population. Dr. Aya will brief us more about the role of the private health sector in universal health coverage. Since the pandemic started and we are talking about the drop in the essential services and the importance of ensuring its continuity, public sector alone in most of the countries in our region never ever maintains the essential health service alone. Private sector provide more than 70% of the modern methods for the contraceptions and for the treatment of the diarrhea and the treatment of the acute respiratory infections for the children under 5. Dr. Reza will talk about Universal Health Coverage Priority Benefit Package and our effort to develop the Essential Health Service Package as a response to the COVID-19. WHO targets for 3 family physicians per 10,000 population by the year of the 2030. And to overcome the current severe shortage in the family physician, and in full collaboration with our colleagues from UNICEF and WONCA, we developed the online regional professional diploma in family medicine. Dr. Saeed will give us more detail on this. And as a practical steps to implement the Astana Declaration and to put the primary healthcare operational framework into action, and with support from the Bill and the Melinda Gates Foundation and UNICEF and our colleagues from WONCA, we developed the primary healthcare measurement and improvement initiative. Today, our colleague Hagar and Roberta will present the first endorsed profile from the region. Based on this, we are going to move next year, inshallah, for the improvement phase in number of countries. Let us start with this topic as a first presentation in our webinar. Over to you, Hagar and Robert, please.
Thank you, Dr. Hassan, and thank you everyone for joining us today. My name is Hagar Azab, and I'm the regional focal point for coordination of the Primary Healthcare Measurement and Improvement Initiative.
And I am Roberta Tosquis, the regional focal point for the PHCMI progression model.
To begin, today we'll go over the PHCMI initiative, its objectives, its achievements during the 2019-2020 period, and its goals for 2021. To begin, we'd like to show you a short video to introduce PHCMI, which is how we will refer to the initiative from here on out.
The Primary Healthcare Measurement and Improvement Initiative, PHCMI, is a regional initiative designed to transform the current state of primary healthcare, PHC. While measurement of the performance of PHC is a key factor, it is only the first step in strengthening PHC. The primary goal of PHCMI is to support regional efforts to drive improvements to PHC based on the collection of accurate, reliable, and routine data. In line with the global goal of achieving universal health coverage, PHCMI aims to use assessment to inform strategies to improve PHC. PHCMI. Measure to improve.
So, in summary, PHCMI is a regional initiative aimed at building national capacity for assessment-based PHC improvement and focuses on developing tools for policymakers to use as scientific evidence for improvement-driven strategies. It's also a joint initiative between the Department of Universal Health Coverage, Health Systems, and the Department of Science, Information, and Dissemination at EMRO, is supported by the Bill and Melinda Gates Foundation, UNICEF, and the World Organization of Family Doctors, and collaborates with the Primary Healthcare Performance Initiative. The PHCMI framework is composed of 5 domains that represent the chain of primary care service delivery. These 5 domains are systems, inputs, processes, outcomes, and impact. Each domain consists of relevant measurable components for which quantitative and qualitative data is collected. PHCMI was first launched on World Health Day in April 2019 by our regional director, Dr. Ahmed Al-Mondari, and 3 countries, Egypt, Jordan, and Pakistan, were invited to participate in the pilot. In July 2019, PHCMI was first introduced to all member states of EMRO, and 20 countries were successfully recruited to participate out of 22. By September 2019, the pilot countries had produced draft profiles, and PHCMI implementation training and data collection began with the remaining 17 countries. Due to the COVID-19 pandemic, planned missions and in-person support workshops for countries were unfortunately postponed, and we conducted the first virtual workshop in May of 2020, where 6 countries presented their draft profiles. By September of 2020, and despite the challenges of COVID-19, 11 countries had produced draft profiles, and we began reinitiating PHCMI work with countries who were able to do so. Today, there are 6 countries who have completed their profiles, with 5 more in the final stages of doing the same, and we have reinitiated data collection with most of the remaining countries. As the first initiative of its kind to assess PHC on a regional level, inevitably there were some challenges in implementation. First, the reliability of data poses a challenge in the region in general, but this is especially true for PHC data because data routes are not always clear, and where there is data, it's sometimes difficult to validate. Another challenge in implementation is coordination. PHCMI is a multi-level, cross-departmental, and cross-organizational initiative that requires collaboration on a global, regional, and national level. Finally, the endorsement of data is a vital step in completing the assessment. Ministries of health are involved throughout the data collection and validation process, and ministerial endorsement is required before publication. This is often a lengthy process and was further delayed during the COVID-19 pandemic. Further to the routine challenges of implementation, the COVID-19 pandemic posed new challenges during 2020. First, countries quickly became overwhelmed with the prevention, detection, and management of COVID-19 cases at the primary care level. Second, and because of this, redistribution of all health professionals to focus efforts on COVID-19 response shifted priorities. And third, the PHCMI assessment was delayed as many of the PHCMI focal points were among the national response teams for COVID-19. However, and as part of the virtual workshops conducted by EMRO, participating countries were able to share the challenges and lessons they've learned, which has provided us with insight on how PHC assessment needs to be reshaped in the near future. Nonetheless, and despite these challenges, many countries were able to complete the assessment, and a few were even endorsed by the ministries of health. With that said, we would like to take this moment to offer a huge congratulations to Jordan, Libya, the Islamic Republic of Iran, and Pakistan for concluding the measurement phase of PHCMI and being the first set of countries to develop, endorse, and publish their profiles. Egypt and Morocco have also completed their profiles and are pending final sign-off by the ministers of health. And this is what the final product for each country looks like. All endorsed profiles will be available on the PHCMI website, linked at this slide when the PowerPoint is distributed, and will be shared following the webinar. Each country will have 2 profiles, a primary healthcare country profile, or PHCCP, and a vital signs profile, or VSP. While the PHCCP includes VSP indicators, the VSP is developed in collaboration with the Primary Healthcare Performance Initiative, a sister global initiative, and contains an added qualitative assessment under its capacity domain, which my colleague Roberta will describe further.
So the qualitative assessment that my colleague just mentioned is called the progression model. The progression model is this mixed method tool which is used to systematically measure the core primary healthcare capacities like governance, the availability of essential service delivery inputs, and the population health and facility management. It is a participatory process which capitalizes on the information that is already available in the country, but maybe it's rarely easy to use for the decision maker. So it is a mixed method tool, which means that it relies on documents review, quantitative data extraction, and key informant interviews to complete the assessment of the capacities. So similar to the initiative in general, also for the progression model, there are challenges. Some are inherently related to the assessment, like, for example, the access to data can be difficult, and also the progression model requires the interview of several key informants, which can be governmental and non-governmental informants, policy expert, academia representative, civil society representative, community representative, etc. So it may be difficult to reach out to them, and also for them to allocate time for the interview. And also the progression model includes both a national assessment and also an external validation. So it's a double assessment, and in order for the progression model to be finalized, for the results to be published, an agreement needs to be reached between the two assessments. So the challenges can be posed by the addressing of the discrepancies between the two assessments. Of course, obviously, COVID-19 amplified these challenges, and it became a priority for the Ministry of Health. And so the progression model was delayed because efforts were shifted towards the COVID-19 response. Of course, sometimes the Ministry of Health would be closed, or the restriction and the teleworking made very difficult to conduct interviews or to reach out to the owners of the document that were needed for the assessment. And also a key challenge, maybe the main one, was related to the impact of COVID-19 on the primary healthcare capacity. And this means that the results would vary greatly depending on whether the assessment was conducted before, after, or during the pandemic. So the initiative started in 2019, as Agar mentioned, but however, several countries started the progression model, the work on the progression model, only in March 2020, unfortunately, right before the pandemic hit the region. So it was very hard, but despite that, as you can see from the table, many countries managed to reach considerable results. So you can see that Morocco, Oman, and Pakistan finalized the assessment, and Bahrain and Islamic Republic of Iran are next in line. They are very close to the end. Egypt, Jordan, and UAE are in the phase of collecting the data, and Iraq and Palestine just started very recently, but anyway, they're proceeding with a very fast pace. And finally, Afghanistan will literally start tomorrow. So all these countries are expected to finalize by March 2021 and to present the results during our next workshop.
Okay. So as you can see, although much has been accomplished so far, there's still much work to do, and we hope to finalize the assessment during 2021. Moving forward, PHCMI work will be focused on three main objectives. The first is continuing the assessment and finalizing profiles for 14 additional countries. Second, publishing 20 profiles by September 2021. And third, continuing to support countries in developing and implementing improvement plans based on the collected data. Thank you so much for your attention and joining us today to congratulate the first countries to complete the assessment. For questions or comments related to PHCMI or any of the coming presentations in general, please feel free to scan the QR code on the screen or follow the link on the invitation to submit them, and they will be addressed later during the session. Thank you very much.
Thank you very much, Roberta and Hagar. Our colleague, Dr. Tomomi, Child Survival and Development Specialist from UNICEF, she's going to give us more details about the online training course for the primary health care physician about the COVID-19. Over to you, Tomomi, please. Thank you.
Thank you very much. Good afternoon, good evening, colleagues. My name is Tomomi Kitamura from UNICEF Minaro. Hope you can hear me. And thank you for having me today. I would like to briefly go over online training, the role of the primary healthcare in the context of COVID-19 pandemic. Next slide, please. Okay, why online training for now? So this training is for the frontline primary healthcare workers, because you are the ones who are providing the health services for all, saving lives in this very difficult time. So this training is to support you to maintain essential health services, assist you in controlling pandemic while ensuring your own safety. The training aims to highlight the important role of the primary health care and provide up-to-date information on policies and guidelines related to COVID-19, identify roles and responsibility of the primary health care team in controlling and preventing COVID-19, and then also to present and discuss WHO workforce infection control procedures for COVID-19. Next slide, please. So who involved in this training? So as a part of the regional work plan implementing SDG 3, we have 6 organizations: WHO, UNFPA, UNAIDS, UNHCR, WONCA, and UNICEF. Next slide, please. So how does the training look like? We have 5 modules covering important 4 functions. The 4 functions are maintaining essential health services, preventing COVID-19 through effective public health measures, diagnosing COVID-19 and ensuring appropriate referral, and managing mild and moderate COVID-19 cases. This course is self-registered, self-paced, now available in 4 languages, including Arabic, English, Farsi, and French. And then you can access this course through web, even using mobiles and tablets. The course is going to be updated every 2 months, and you will get the certificate at the end of the course, and then it is accredited by American Association of Continuing Medical Education. And then the course itself is endorsed by Arab Board of Medical Specialization. Next slide, please. So when you log in, you get a little bonus that you get the personal message from the 6 heads of agencies. And up to now, we have 15,000 participants registered, and then 70% of them have already received the certificate. But we are aiming very high. So we would like to have 50,000 registration by the end of next year. So please do join us. Next slide, please. So what do the participants think about the training so far? From the feedback form at the end of the course that we're receiving the quite high satisfaction rates, the participants are saying that they would like to recommend this course to colleagues and friends. And then I'm also hearing from some of our UNICEF colleagues that they would also like to recommend this course to UNICEF staff as well. In addition, the participants are saying that they would be willing to participate in other online courses if we develop one, being encouraged by these comments and feedback that we are having a plan to develop a similar course specific for nurses and midwives. Next slide, please. Just to summarize my presentation, I would like to share the infographics on the online training. And could you start the video, please?
Robust, accessible, and universal primary healthcare is critical for responding effectively to the COVID-19 pandemic. A new online course is now available to help ensure that primary healthcare is fully integrated into the COVID-19 response in every country of the Eastern Mediterranean region. The World Health Organization, UNAIDS, UNFPA, UNHCR, UNICEF and WONCA worked together as part of the Global Action Plan for Health and Wellbeing to create this innovative training. The course covers the 4 main functions of primary healthcare in relation to COVID-19: maintaining essential health services, preventing COVID-19 by supporting effective public health measures, early detection of COVID-19 cases and ensuring adequate referral, and managing mild and moderate COVID-19 cases. Participants will receive certificates of completion from WHO, accredited for 15 study hours by the American Association of Continuing Medical Education. If you are a primary healthcare physician working in the public or private sector in the region, we strongly encourage you to complete this training.
Next slide, please. Thank you for being our heroes at the front line. Over from my side, over to Dr. Hassan or Dr. Saeed. Thank you.
Thanks a lot, Dr. Tumomi. Before we'll go for opening the floor for the questions and the answers, Dr. Saeed is going to brief us about our initiative for the regional diploma in family medicine for the primary care. Over to you, Dr. Saeed.
Thank you, Dr. Hassan. I'm Said Suleiman. I'm a WHO EMRO PHC consultant. I'm talking today about a project to empower PHC physicians through family medicine training. I'm talking about the Regional Professional Diploma in Family Medicine. Why we need a WHO Regional Professional Diploma in Family Medicine? First, to overcome the severe shortage of family medicine in the region, and this is very essential for universal health coverage. And second, it's a chance of capacity building for uncertified generalists and physicians who want to be certified in family medicine. This will ultimately lead to upscale of the PHC quality of service delivery and reducing the adverse consequences attributed to common disease in the member states. The story of the Regional Professional Diploma in Family Medicine started by resolution number RC 63, where the WHO East Mediterranean Office asked the member states to create bridge programs to generate or to graduate family medicine doctors in the region. Consequently, the WHO EMRO, in collaboration with the UNICEF and with the World Organization of Family Doctors and the American University in Beirut, generated or created a one-year certificate entitled the Regional Professional Diploma in Family Medicine. In the RC 66, our regional director, Dr. Ahmed Manzari, advised to create a steering committee of the Regional Professional Diploma of Family Medicine with the following terms of reference: to act as a governing body to develop policies, plans for implementation, to set the criteria, standards, and the parameters for the program, and to develop policies and procedures for monitoring and evaluation of the program, and provide support and guidance for the member states to customize the program to their national needs, as well as recommend the approval of the curriculum and the approval of the institutions or perform any other function deemed necessary for the planning, implementation, and evaluation of the program. The curriculum of the Regional Professional Diploma carries the merits of a blended learning, meaning most of the doctors are full-time employees, so part-time and full-time streams are available. It covers the core knowledge and the skills needed to graduate a good or a professional family doctor. The online to live component is 4:1, meaning 80% of the curriculum is provided in online format and 20% is field training or face-to-face training. It expands or spans over 12 months and it's composed of 8 blocks. Each block is on average 5 weeks. We set a guide or a roadmap for implementation of the diploma for the countries. Start by the first phase, in which setting the stage occur, like planning the process and assigning the supervisory team and setting up e-learning server and acquiring content from the WHO. In the second phase, we are recruiting trainees and tutors. And then third phase, we are launching the program with the logistics, with enrollment exam and interviews. We are forming groups and we're doing orientation. In the fourth phase, we are doing the actual teaching and learning of the program, either on the online part or the self-study and face-to-face part, as well as the portfolio and assessment. We identified many regulatory and institutional and other challenges for implementing the program. To overcome some of these challenges, we conducted series of training of trainers programs for member states. In this year, we conducted a face-to-face TOT for Egypt, and then came the COVID pandemic, and we rapidly converted our training into a virtual TOT for Palestine, Bahrain, and Syria. The objective of this was to introduce the curriculum of the diploma and train those academics and experts how to conduct the training via our online learning management system, and to engage them into implementing and creating a country-specific action plan for implementation. The content of this virtual TOT spans over 7 days. In the first day is introductory session. In the second day, you are getting started with our learning management system. In the third day, we are setting the curriculum and the implementation plan for the regional professional diploma in family medicine. In the fourth day, we are navigating through a model as instructors or facilitators. And in the fifth day, there is homework that they are planning or starting planning their action plan. In the sixth day, we are discussing those action plan. And in the seventh day, we are presenting those action plan to be ready for action or implementing to those specific country. Other way to implement or fully implement the regional professional diploma is converting the online component, which is 80%, to be fully automated. Fully automated means that it is self-enrolled, self-paced, so the student will not need an online tutor or teacher to help him navigate through lessons and module. But for the 20% remaining part, we will still needing training centers for this part. Thank you so much, and any questions?
Thanks a lot, Dr. Said. Let us move for the questions. Hagar, do we have questions?
Yes, we just got a couple of questions in. Dr. Said, Dr. Said, this one's fresh off the press for you. There's a question asking how many countries have endorsed the regional professional diploma?
Okay, we have this diploma in Lebanon, we have it in United Arab Emirates, and very recently in Jordan, and we are working to implement it in other countries like Syria, Palestine, and Libya, and more countries to come, inshallah.
Great, thank you. There's one other question related to PHCMI, so I guess I'll answer that one. And it's, how does Emerald plan to utilize PHCMI as a tool for improving PHC services in the region? PHCMI is intended to come in 2 phases. The first being measurement, the assessment that we're currently conducting, and the second being improvement. And this was a priority when developing the initiative to begin with. And the idea is to identify gaps, weaknesses, as well as strengths and challenges from the data that we collect and present in the profiles. And then from there, work with countries to prioritize some of the gaps or weaknesses that they've would like to focus on and that are feasible in the time moving forward.
If you can allow me for this to add to it, yes. So far, we already completed the measurement phase for a number of countries, as already Hagar kindly presented in her PowerPoint presentation. Next year, very soon, we are going to move from the measurement phase to the improvement phase for this. So if we are talking about whatever the gaps for the improving of the primary health care, like for example, about the referral, for example, about the finance, whatever the gap that we are going to focus on it over the coming year for the 2021. Thank you, Hagar.
Thank you, Dr. Hassan. There's another question for Dr. Said. In what institutions are you hoping to administer the regional diploma?
It varies from country to country. So we are exploring every country's special situation. And in some countries, there is a collaboration between the Ministry of Health and certain academic institutes to set up a committee or a subcommittee for implementation in this country. And we are choosing the training centers or training places, either from the Ministry of Health or from academia. Okay, so it is not set up plan for country. Each country is tailoring according to the needs, to the available tutors or academics or experts in family medicine, and according to even the students' needs.
Thank you, Dr. Said. This next question is for Dr. Tumomi, who's with us online. And the question is asking, will the training be adapted after the COVID situation has passed? Dr. Tumomi.
Okay, thank you for the question. So that training is going to be upgraded every 2 months based on the evidence coming from the COVID-19 situation and the new guidance based on that evidence, so that it's going to be upgraded and changed according to the situation and guidance. Over from my side.
Thank you very much, Dr. Tamomi. Dr. Said, you're popular with us today. The next question is asking, okay, to Dr. Tamomi and Dr. Said, I guess, whichever you'd like to answer the question. The question is the diploma available in Yemen or Aden?
We hope so very soon, but still not available yet. Okay, so we are working to be available in every member state country.
Allow me to add to this. We are actually working on developing a fully automated regional professional diploma, in which this will give a wonderful chance to the candidate to go on direct and log in and start to get his diploma within a year. And we are going, this is talking about the 80% of it, which is the online. For the face-to-face, we are going to work on it, and we are going to identify a number of the training centers in the region that we are going to contact with it, and we'll take it from there. Thank you.
Thank you very much, Dr. Said and Dr. Hassan. There's a question regarding the online course asking, is it free and will it be available on the WHO website, and will there be a certificate upon completion? Dr. Tamomi or Dr. Said?
Okay, I think I can come in and Dr. Said can help me. So I think this is free and this is self-registered. And then I think that I didn't share the link, but I guess that my WHO colleague could just maybe share the link after the webinar. And then also you will get the certificate at the end of the course from WHO, and then also the certificate is accredited by American Association of Continuing Medical Education. Over from my side, Dr. Said, if you'd like to add anything from your end.
Thank you, Dr. Tamomi. This is actually perfect. I would like to add that's very free, self-paced, and after COVID, we are even now, there is a lessons of post-COVID rehabilitation and how to do psychological support for doctors and for patients even after COVID. We are talking about this post-COVID syndrome that can last up to 3 to 6 months. In this course, you'll find lessons covering that, helping family doctors to do this post-COVID rehabilitation. Other thing related to this course, we are continually updating it, so it will continue even after COVID. So if we are introducing vaccines, there will be a lessons regarding vaccines, regarding prevention. So it will continue to have a role even after the termination or the end of the COVID crisis.
Thank you very much, Dr. Said. We'll take one more question before we move on. And this question is asking, will PHCMI be open to engage civil society organizations and private sector for the improvement phase? Like we mentioned just a little bit ago, the improvement phase will be tailored on a country-by-country basis and based on the needs and priorities of the country. And should there be a necessity for involving these organizations, I think we would take that opportunity to develop a plan that does involve them with the countries. But we are relying on country guidance to provide us with their needs and priorities and their insight really on who best to involve as the stakeholders in the process. Over to you, Dr. Hassan.
Thank you very much for the very good questions. We are going to move to the next topic. Dr. Reza kindly is going to brief us about the Universal Health Coverage Priority Benefit Package and WHO effort for developing of the essential service as a response to the COVID-19. Over to you, Dr. Reza. Thank you.
Thank you so much, Dr. Salah, for giving me this opportunity. Good afternoon, ladies and gentlemen. What I want to talk about today is the service package. I want to say why now the service package is more needed than ever to realize universal health coverage. Let us start with a short video on the service package and a new product of the WHO, which is very instrumental in this regard. Mr. Karim, over to you. Can you start the video?
Countries around the world are working to accelerate progress towards universal health coverage. To do that, a key step is to look at population needs and identify a core set of health services that can be provided at a cost they can afford. Delivering on universal health coverage means something different for every country, with different service packages that grow over time as more resources become available. To help countries tailor universal health coverage to their needs, WHO has developed a resource that shows different options and scenarios, the UHC Compendium. The Compendium is a database that lists actions that countries can take to improve the health of their populations. Countries can use the information in the database to answer specific questions. For example, what are the different patient needs that the health system should plan for? What options do I have to deal with HIV, malaria, diabetes, or any other condition? How do I plan the resources to deliver them? What health workers are required? Which medicines and products do I need? Countries can search for information relevant to them in order to define a service package and identify the resources needed to deliver it successfully. In this way, the UHC Compendium offers vital information and tools to develop reliable data, to start a dialogue with partners, and to make evidence-based decisions about how available resources can best be used to ensure that everyone gets the healthcare they need. Visit the UHC Compendium website now to see how it can support your country to boost universal health coverage.
Can you, sorry. Thank you so much, thank you. Well, by today's talk, we want to report that 4 countries of the region were involved in defining service package during last year. I want to say that why expansion of services is crucial in advancing UHC, and explain the example of Somalia as one of the 4 countries involved in service package this year. And finally, point out why the package is more important than ever in the COVID era. From the beginning, more than a dozen people have contributed in these 4 countries. Definitely, I do not want to name all people right now, but invaluable efforts have been taken in Jordan, Palestine, Pakistan, Somalia, and Sudan. Each has its own merit. If we look at the Universal Health Coverage Monitoring Report 2019, among these 4 countries, we have Jordan, which has 76% service coverage and 28% out-of-pocket payment. For a country like Jordan, defining a service package means improving efficiency. For a country such as Sudan, where service coverage is low and financial risk is high, the country needs a comprehensive reform in both service delivery and health financing. This is why universal health coverage with primary health care approach is crucial for all these countries, because it provides the equitable range of services people really need while protecting them from financial hardship. This is the reason defining service package was considered as the strategic direction in the region. And in 2019, a guide to developing a service package was prepared, which translated into country action in 2020. Getting back to the outline of the talk, let's focus on one of these 4 countries and look at Somalia in more details. Among these 4 countries, you can see the situation of health indicators in Somalia, which is not satisfactory. It has the highest under 5 mortality globally, the second highest newborn mortality, and the 6th rank of maternal mortality in the world. Look at the services, the BCG vaccination coverage is just 12%, and just 22% of pregnant women got vaccination. So one of the main causes of this situation in Somalia is the weak service provision. Practically, when we worked with each other, in the Somalia, we understood that the burden of disease of Somalia is in this way. Suppose, regarding disability, mental health is high, but at the same time, it was not addressed appropriately in the current service package of the country. You can see here the burden of the depression and anxiety, which was not included in the existing service package of the Somalia. So in this slide, you can see as an example sepsis, which is by using some modules of the UHC Compendium, we look at the all evidence-informed, cost-effective interventions suitable for country which were determined, and to look at each level of care in Somalia to understand what should be offered in which level. Here you can see from community level, health post, health center, district hospital, and finally the national or regional hospital, which services should be provided in which level. And based on that, the package was prepared, this package costed, and it was estimated how much the package cost would be in different scenarios until 2030. The result is that if the service package provided the coverage seen in the scenario by 2030, the mortality of pregnant women will be less than half, and more than 200,000 children will less suffer from stunting by using this package. The work is now finalized in Somalia. On December 3rd, various partners came together to discuss the package implementation. It is clear now, based on the package, what changes should take place in the health system. For example, in financing, there must be pool funds of donors. Adequate contractual arrangements must be developed. And it is clear right now that what we need a project coordinator and implementation unit in the Ministry of Health of Somalia. And what are the requirements of human resources? This is completely clear based on the services right now and how we can actually improve and strengthen the health system of the country. Getting back to the COVID issue, now during the COVID, the need of maintaining essential health services, as Dr. Salah has mentioned, is one of the high priority areas. I want to say that first, for the services disrupted during peaks of COVID, we have problem. They have disrupted. Hypertension, cancer, diabetes, infectious diseases, tuberculosis, all of them has some sort of actual disruption. Second, surge needs of the mental health support and care as a subsequence of pandemic. And the third, diseases due to poverty, which is the actual long-term economic impact of COVID, which is coming in the long run. In many cases, the burden of these could be greater than the direct effect of COVID. The WHO has developed guidance for maintaining essential health services. The first step of the guide is recognizing health services priorities. And this is another actually way, and it is another window of work which shows us how prioritization of the health services is required, and it is a need now more than ever. So we're done with my slides, and now we know that the region has experienced, practical experience at the country level, and the tools are accessible. Especially amid COVID, this prioritization is needed. My conclusion is defining service package is one of the key components of moving towards universal health coverage and health for all. We now have successful practical examples at the country level in the region. And finally, that COVID showed defining a prioritized explicit package is a step to having a resilient health system and protect everyone with the hope of health for all, by all, and protect everyone. Thank you so much for your attention. Thank you.
Thanks a lot, Dr. Reza. Very good presentation. Before we will move to the second slot for and this will be the last slot for the questions and the answers, please share your questions so we can answer it later on. Dr. Aya, she is going to share with us about the situation for the private health sector as a role in the universal health coverage. Over to you, Aya.
Thank you, Dr. Hassan. Good morning, good evening, everyone. Thank you for joining us today to talk about the importance of the private health sector and EMRA's work in engaging with it. So first, I'd like to start off by a quick definition of what we mean by the private health sector. The World Bank defines the private health sector as all actors outside of the government, including for-profit, not-for-profit, formal and informal entities. This includes pharmacies and pharmaceutical companies, service providers, suppliers, and traditional healers. I just want to point out that the focus of our work in this presentation is about formal service providers and largely those that are for profit. I'll also want to mention that from this point onward, I'll be referring to the private health sector as PHS. Now, why is PHS important? The private health sector in the Eastern Mediterranean region is responsible for 33 to 86% of outpatient services. It's also responsible for up to 81% of the health services used by the poorest quintile, and over 60% of EMR pharmacies are owned by the private health sector. The private health sector also has massive healthcare resources. In high-income countries, 6 to 22% of hospital beds and 15 to 88% of PHC facilities are owned by the private sector. In middle-income countries, the figures can even be more staggering, with 7 to 83% of hospital beds and 5 to 78% of PHC facilities being owned by the private sector. Similar pattern is also observed in low-income countries. Now, why is engaging with the private health sector important? The problem is that the private sector has expanded with limited national policy direction and is often excluded in public health sector planning. This is one of the reasons why we have high out-of-pocket expenditure that could reach up to 60% or more in low-income countries, and the fact that almost half of EMR populations doesn't have access to the essential health services. We believe that contracting with the private health sector to deliver essential health services will help member states achieving universal health coverage. In the next couple of slides, I'll be walking you through the work that has been done so far in this regard. In 2018, WHO has developed a framework for engaging with the private health sector. This framework includes 5 strategies. The first is developing a policy framework for financing strategies, developing strategic options, including strategic purchasing, improving the quality of services in the private health sector, and ensuring the enforcement of regulatory mechanisms and the development of monitoring and reporting mechanisms. Based on this framework, and over the last 2 years, we have worked on 4 main projects. The first is conducting an in-depth assessment of the private health sector in almost all countries of the region. The second being assessment of the potential role of the private health sector in COVID-19 response. And the third is conducting a thematic analysis or a deep dive into the role of the private health sector in specific health topics. And finally, engaging with the private health sector in multi-sectoral policy dialogues. For the in-depth assessment of the private health sector, 17 countries have already completed the assessment, which included aspects as financing, access, quality control, public-private partnership, and governance. So far, 13 countries have cleared their respective reports. For the assessment of the potential role of the private health sector in COVID response, 11 countries have been selected by WHO, USAID, and GAP Accelerator partners to conduct an assessment of the potential engagement of the private health sector in the whole of the society response to the pandemic. To date, 7 reports have been completed and submitted for clearance. As mentioned earlier, we have also deep dived into the role of the private health sector in different topics. Those are 11 topics that include protracted emergencies, health financing options, communicable diseases, non-communicable diseases, and many others. In the interest of time, I won't go deeply through all of them, but please feel free to reach out to us for more details. And finally, for the policy dialogue on the engagement with the private health sector, 5 countries have been selected to conduct a series of 3-hour workshops of national multi-stakeholder dialogue for effective engagement with the private health sector. The next steps for us would be expanding the policy dialogue to include other EMR countries and complete the ongoing assessment projects and seek MOH endorsements. Finally, I'd like to leave you with a short video that summarizes the key points discussed in my presentation.
The health sector includes all actors outside of government providing health or health-related products and services. In the World Health Organization Eastern Mediterranean region, many people use the private sector for access to essential health services. Although the private health sector plays a very active role in providing hospital and outpatient care, it is largely not included in public health sector policy or sufficiently regulated. The private health sector has a major role to play in the achievement of universal health coverage. In October 2018, the countries of the region adopted the 5 strategies of the WHO Framework for Action on Effective Engagement with the private health sector for universal health coverage. Developing a policy framework. Developing strategic options, improving the quality of services, ensuring the enforcement of regulatory mechanisms, developing monitoring and reporting mechanisms. As part of the Global Action Plan for Health and Wellbeing, the World Health Organization worked with its partners to conduct an in-depth assessment of the private health sector in almost all countries of the region, assess the role of the private health sector in the response to COVID-19, involve multi-sectoral stakeholders in national policy dialogue, analyze the role of the private health sector in different areas. WHO and its partners will continue to provide technical support to the countries of the region to engage with the private health sector for universal health coverage. The private health.
With that, I'd like to open the floor to questions. Over to you, Hagar and Dr. Hassan.
Thanks a lot. Thank you very much for the wonderful infographics, by the way. Okay, Hagar, what question do we have? Yes.
So we have quite a few questions coming in regarding the UHC priority benefit package and a couple for private health sector. So we'll start probably with UHC benefit package. The first is regarding, is there political support or is political support improvement for the development and implementation of the Universal Health Coverage Priority Benefit Package? And why is it considered a priority during the pandemic? Dr. Reza.
Okay, definitely, because it is not a simple task, no doubt. It is completely lengthy process, and you cannot do it without a strong political commitment. This is one issue. The other issue is that people are used to get a service, therefore changing their behavior, as well as changing behavior of the service providers, is not actually easy task at all. Therefore, it needs a high political support, and this is something that we need, not for defining, because defining is a list of services. For implementation is much more important than the development itself. Okay, why it is considered as a priority during the pandemic? The issue is that right now you are providing actually this list of services, and you want to decide with the situation of the pandemic, which should be provided at the moment as the essentials, which can be postponed and which can be suspended. Therefore, you need some sort of actual prioritization. And right now, an additional criteria is coming, whether disruption of that service can affect health of people or not. This is in addition to the impact of that particular service. We should look at whether disruption can affect the health of people. At the same time, look at the situation of the countries. I'm going to actually shorten my answer. In many countries of the region, we have almost 5% shortages and cut in GDPs. Okay, if we are thinking at the same amount of the money that countries had before, right now we have 5% less. And the COVID itself actually needed much more investment in the health system, for the response, for the vaccine, for the hospitalization, for ventilators, etc., etc. Therefore, the problem asks us that we need some sort of prioritization. At the same time, the basket of countries for providing services right now is much less than before, much smaller than before. Therefore, we should know which services we have, and then this is a basis for the resilient health system, as I have mentioned in my presentation. I hope I covered the question. Over to you, Hagar.
Thank you, Dr. Reza. The next question is for Dr. Aya, or Dr. Hassan, if you'd like to. And it's, how are the private health sector assessments in the region approaching providers? For example, is it through professional associations only, or with a sample of individual providers?
Okay, the question is not very clear, but as far as I understand the question, we conduct the assessments based on an assessment tool that looks into the overall country and the overall policies in the country in terms of governance, the capacity in terms of the available resources in the private health sector compared to the public sector. So the assessment tool is very comprehensive and includes expert interviews as well as secondary data, using secondary data. Sometimes we resort to primary data collection that gathers data from service providers directly, but in case the country had enough resources, then we usually stick to secondary data collection and expert interviews. Dr. Hassan, if you'd like to add something to that.
Yeah, you may ask, for example, why we are conducting this kind of assessment. It's just only to get kind of data and information, and that is it? No. Actually, we are using the results for the in-depth assessment about the private health sector and its role in universal health coverage. This is one topic. In addition to the potential role of the private health sector in COVID-19, these two topics, we are using them for developing of the policy dialogue with the countries. Without having good, reliable evidence about the situation of the private health sector, no way that we can conduct a policy dialogue. And especially if we are going to talk later on with the policymakers, you have to tell them exactly what is the situation. 70%, for example, of the service delivery at the level of the primary health care and outpatient facilities is provided by the private sector. This is major things. So we have to have kind of an evidence, very reliable data. Thank you very much. Over to you.
Thank you to both of you. On that note, there's a question regarding how we can further encourage countries to engage with the private health sector.
Okay, so first, I think the main thing that we need to highlight is the importance of each sector to the other. Countries, I think they already realize how important the private sector is, and usually the gap is how to bring everyone to the table and discuss together how they can work together. There has to be a way in which everyone finds benefit in the collaboration. There has to be a win-win situation. So I think the main issue or the main problem is to make sure that both sectors meet in the middle and find an arrangement that works with both of them and addresses the needs of both of them. Dr. Hassan, if you'd like to add something.
Sure. How can we convince the countries and the policy makers, especially, to go for effective engagement with private health sector? You have to have kind of a legal umbrella for this. When we started our work about the private health sector, this is back of a couple of years ago, we already received an endorsed resolutions from the member states toward effective engagement with private health sector. This is back to the 2018. Based about this endorsed resolution and the framework, we are used as an evidence for us that help us to go for the effective engagement with private health sector. In addition to this, the whole agenda for dealing with private health sector, it is part of our work plan for the GAP Accelerator one about the primary health care. So having our partners, including USAID, Bill and Melinda Gates, UNICEF, UNFPA, UNHCR, UNAIDS, and our colleagues from WONCA working with us about the issue for the private health sector, definitely when you have all these partners, it will give you more power to implement it in the future and to convince with the policymakers. Thank you, Akar.
Thank you, Dr. Hassan and Dr. Aya. The next question is back to Dr. Reza, and it's asking if there is a country experience in the Eastern Mediterranean region where the Universal Health Coverage Priority Benefit Package has been implemented along with needed health systems reforms.
Okay, as I have mentioned right now, first of all, one of the oldest experience that in the region we have is in Afghanistan, which is based on all events that we have had in Afghanistan. They have very strong background of using benefit package, and it was the base of the contracting with the different service providers. It's a while that they have done it. And in 2018 and 19, they actually revisited the previous package. In addition to that, I want to say that it is very interesting whenever you are looking at the region, those countries which are in the fragile situation in conflict, they have very defined service package. I mean, you can see it in Yemen, in North Syria, in Iraq, all of them have package. Why? Because it must be a basis for the donors for the fund actually providing fund for the services. Therefore, we have this experience in the region. In addition to that, I have mentioned these 4 countries that I presented for the 2019 and 18, they have done this. Over to you.
Thank you very much, Dr. Reza. The next question is backtracking a little bit, asking what have been the lessons learned thus far in the PHCMI initiative. And I guess I can answer this. There are a few, but if I could highlight 2, I think one would be the importance of health information systems with specific regard to, in the region, but specific regard to primary healthcare and how it really needs to be reshaped and revisited. One of the common experiences that countries had were the major gaps and fragmentation of data. So even for indicators where we had data, to get to the responsible unit or the responsible person for the data, or to get the sources that are needed to validate the data was quite difficult and time consuming. And it really sheds a light on the importance of EMRO working with the countries to help improve HIS. Another is a need for coordination between existing efforts and projects on a regional and national level. One of the things we discovered with the countries who who have finished the assessment and we're now looking with them to build improvement strategies or an improvement plan based on that information, is that there are often existing projects that actually address some of the gaps or challenges that they've highlighted from the initiative. And we want to work together with these countries to really collect as much overlap as possible so that we're not duplicating work and we're making the most out of existing initiatives and existing projects to improve primary healthcare. We have just received another question. This one's a bit more general, and I guess it's open to anyone who'd like to answer here on the panel. Have there been any experiences documented about the remote and simple innovative ways to adapt health services in primary healthcare regarding COVID-19 in the region? And I open the floor to anyone who'd like to answer that.
The online training.
Have there been any experiences documented about the remote and simple innovative ways to adapt health services in PHC regarding COVID-19 in the region? If you want to tackle that.
I think we are back to the online training. And for this online training, it has been an experience for us. First, we have this COVID pandemic and all learning resources. And we asked ourselves this question. Dr. Hassan highlighted what is the role of primary healthcare in COVID management, diagnosis, prevention, while the people are looking at hospitals and building mega hospitals. Then came the question of forming this online training. Indeed, we didn't expect people to take this training to that level of 15,000 participants in 2 months. Okay, so this is a learned lesson. There is a need in the region for such trainings, and even the experience of this training, because we asked ourselves, what is the modality we are forming? Will it be a live training where some teachers or experts give lectures and the students must be attending on the other side, or we adopt asynchronous policy? And for this asynchronous policy, we learned a little bit of doing less videos and less multimedia, and the student will be faced by much text to adapt to the internet speed in most of our countries. So there is many innovations and many lessons learned from this online teaching, online training for COVID. And actually we are implementing that back to the Regional Professional Diploma in Family Medicine to have the same approaches that worked, and we think it succeeded. There is another thing we are learning now. We are doing a more in-depth evaluation of the impact of this training on even the practice, not just the knowledge or the feedback you showed in the presentation, but how the practice has improved or has difference after taking this training, even month after that.
Just to add to this about our experience in this developing and implementing of this online. Actually, this is the first time, to be honest, to have such kind of experience for the developing an online, and more important than having the package itself, we spend quite time really to develop its contents, because it has to be from very clear technical resources, from either from the WHO, from our partners, UNICEF, UNFPA, and so on. So it wasn't easy thing to develop it. And by the way, when we started this applications and we put it online, we didn't expect to have such kind of huge utilization. In the first week, there was something like maybe 2,000 or maybe 3,000 physicians. All of a sudden, they started to take this training, and then we started to move from the English version to the French, from the French to the Arabic, and from the Arabic, then we decided for the Farsi. So far, we have the 4 languages available. So it is one of the actually very successful experience for us, and we learned a lot. So far, we are started to develop the same online training, but it is going to be for the primary health care nurse, and is going to be available within coming couple of months. We are doing our best to develop it as soon as possible. Thank you, Saeed. Over to you.
Thank you, Dr. Hassan.
Please,
Dr.
please,
Reza, I think,
please.
wanted to comment.
Regarding this experience, I want to seize the opportunity and actually inform the participants that tomorrow from 11 Cairo time, which is 2 GMP. We have one another webinar, which is about the maintaining essential health services during COVID, which is countries are going to present their experiences, and we have a specific panel for primary healthcare as well. I wanted to seize this opportunity to mention it. Thank you. Over to you.
Very good strategy, Rosa. This is great to take the opportunity. Yeah, over to you, Hagar.
Yes, thank you, Dr. Reza, Dr. Hassan, and Dr. Saeed. There is another question regarding the Universal Health Coverage Priority Benefit Package, and I think it might be our closing question. Does WHO have a plan to implement the priority benefit package in the EMR?
I want to actually look at these 4 countries. Let's look at the Somalia. Somalia service coverage was 26%, one of the lowest actually coverages globally. Therefore, they have developed very strong plan for the expansion of the UHC. This is the reason that they have started. And at this moment, we are in the UHC days. It is worth mentioning that the late Peter Salama, which was one of the main initiators of this work in Somalia. And it was very systematic work because it started from the problem of low coverage of services in Somalia, and the person who was enthusiastic to provide health for disadvantaged people. I wanted to seize and mention his name. This is the case for Pakistan, that Pakistan is looking for universal health coverage in very systematic way. And we had similar actually issue in Jordan. They have started with strategic purchasing, and the defining service package came from this actually strategic purchasing thinking. In Sudan, they have started with the new government of looking at how they can provide better services for people, for the welfare of people. Therefore, it is very strategic thinking. At the same time, Dr. Mataria has mentioned about the UHC declaration and the global commitment that countries have. And this work on the UHC priority benefit package came from the UHC action framework, which the regional office has developed in 3 or 4 years ago. I mean, Dr. Salah can correct me. And then I want to say that this is the global compact, especially within the region, there is a huge commitment. But it is not easy way to do, and it needs financing for the provision of the service. Therefore, it needs much more. It needs political commitment, as you have asked me in the first question. Hagar, over to you. Thank you.
Thank you very much, Dr. Reza, for the insightful response. We have 2 questions for Dr. Aya and Dr. Hassan. The first is, while doing expert interviews, are you interviewing in private sector? And the second is, do you have a synthesis or stories from the field on how private sector has been effectively engaged in the EMR?
For the first question, yes, the expert interviews involves people who are responsible of the private health sector, like government officials, and it also involves people who are working in the private health sector, and in the private health sector, mainly by that we mean the service providers, because that's our main area of focus. And the second question was about the success stories. Yes, and this was particularly highlighted in our very recent project on the assessment of the role of the private health sector in COVID response. So we identified a lot of good examples of engagement and collaboration with the private health sector in many countries of the Eastern Mediterranean region. And also we were able to identify areas where more work can be done and areas of improvement for the same thing, and learning from the country's experience and sharing experiences within the region. So yes to both, I guess. Dr. Hassan would like to...
Sure. About a successful experience in the region. Yes, definitely we have a very good successful experience. Lebanon is a typical example for this. They have full engagement with private health sector. Iran has a wonderful, comprehensive approach for dealing with a private health sector, and in particular for the family practice in which they are contact the family physicians and have a contract with them, and fully engagement based about very clear packages. This is very good examples. In addition, of course, several GCC countries in Saudi Arabia, in Bahrain, in Emirates, there is very good examples about this. But we want our point about this issue for the private health sector to be a kind of routine. This is our work. I mean, our main problem for the private health sector that it is the very high out of pocket. In most of the countries in our region, actually the country with the highest out of pocket globally, it is from our region. So we want to go to encourage the countries for such kind of engagement with private health sector. Thank you.
Thank you very much to the both of you. This next question is for Dr. Hassan, I suppose. Is there an operational guidance for WHO to maintaining essential health services? And if so, can you share it with the participants? Or yes, the question is there an operational guidance from WHO for maintaining essential health services? And if so, can you please share it with the participants?
Definitely. This is very strong actual guidance. And this is one of the brilliant products of the organization. I really enjoy whenever I'm working. And I showed during my presentation, the first page of it, and you can look at the name is Operational Guidance on Maintaining Essential Health Services During COVID. And it is very clear. At the same time, I want to add that the regional office has prepared a tool for supporting countries in this regard. And in the last regional committee that we had just in October this year, one of the main topics was actually was about the importance of the continuity of essential health services. And the regional office has a great commitment to work with countries in this regard. If there is any question and then you could not find these materials, please contact us. Definitely, it's more than that. We are more than happy to share with you. Over to you.
Thank you, Dr. Reza. There is another question regarding private health sector for Dr. Aya and Dr. Hassan, and it's decision makers may not always realize the vague differences between privatization and partnership. So how do you plan to address that?
We're in constant discussions with, and we're in close contact with the governments, and we are working closely with them to address their queries and their concerns, and we constantly work to clarify the differences. Also, the planned policy dialogue workshops that we are intending to have, I believe, will bring closer the points of views and will address all of these issues that will address those concerns. Dr. Hassan?
Can I just add for this?
Yeah.
Yes, this is thank you. This is a typical question. Whenever we are talking about effective engagement with private health sector, then response say, oh, are you going for privatizations? Are we going to sell the public primary health care facilities which give the service to the poor people and they will give it for the private sector in which later on the patients are going to pay the full cost of the service? The answer is not. We are far, far away from this. So far, the people go for the public sector and for the private sector. For the public sector, supposed to be for free. And for the private sector, the current situation, very high out of pocket. Our point is that later on, with the full engagement with private health sector, that the patient will go for the private sector or for the public, both of them, and it is going to be with the same quality, with the same price for the cost. So we are far away from this issue of privatizations. Thank you.
Thank you, Dr. Hassan and Dr. Aya. Do you think we have time for one more question, or should we move on?
Last question, yes.
Okay. It's also related to private health sectors. So COVID has opened further avenues for innovation in health service delivery. And the question is, how is WHO EMRO engaging private sector for institutionalizing innovations done at the country level?
At the beginning, as I mentioned, that many countries actually, they announced it, the governments, they announced it and put it very clear is that the COVID-19, it is full responsibility of the public sector without touching at all the private sector. It didn't work at all. A couple of months, as I mentioned that, and because the countries are in need to increase their capacity for the service delivery, they went for full engagement with private health sector, and the private sector in many countries right now, they offer the tests and for trace of the COVID-19, in addition to for the treatment. So my point is that the private sector is playing a major role about the COVID-19. And then we realize that we need to conduct kind of an assessment. What exactly is the situation and what exactly is the potential role of the private health sector in COVID-19? That's why we approached around 11 countries. So far, we already received the report from 7 countries. More than this, we sent back to the ministries of health to get their clearance about the contents of this report. We are going to use this report as a model, as an entry point for the policy dialogue in the future, and to tell the policymaker, look for the situation. We are using the COVID-19 as an example for effective engagement with private health sector. Thank you, Akar.
May I just add, build on what Dr. Hassan has said? I think the main problem that we have now is that we don't have the enabling environment for full engagement with the private sector. And so the COVID experience has provided a good base to build off this discussion and also the work that we have done at EMRO. So I think we can't really talk about institutionalizing something without having the legal framework first. And that's our main focus of work. Yeah, thank you.
Great. Thank you both. And thank you to the rest of the panelists for taking the audience questions. I'll pass it off to Dr. Hassan for closing remarks.
Thank you very much. Thanks a lot, really, for the very good questions and the good discussion. We are a couple of weeks from the end of the 2020, and we'll always remember it with the impact of the pandemic that infected more than 4 million from our population from the Eastern Mediterranean region and left over 100,000 dead in less than 12 months. Primary health care is recognized as the most inclusive, effective, and efficient approach to achieve universal health coverage by the year of the 2030. Universal health coverage will continue as a dream for many countries as long as their primary health care sector are facing the current serious challenges. In these countries, almost more than 93% of the public primary health care facilities still are managed by generalized physicians, and they are not a general practitioner and they are not a family physician. These countries doesn't provide comprehensive treatment for the non-communicable disease, and all of us, we know that almost 62% for the mortalities is the responsibility for the non-communicable disease. 70% of the outpatient services are provided in these countries with the private health sector with very high out of pocket. These countries actually they are facing critical shortage of the health workforce. Lots of challenges about the quality of the service. Antibiotics, by the way, in a number of countries are provided in 75% of the prescriptions. Essential service package in these countries still are implicit versus to be an explicit, which actually reflects the policymakers' vision for these packages. And if the country is under emergency, all of us, we know the impact on the infrastructure and the health workforce. In the 2020, the pandemic has amplified all these challenges and limited the inclusive role of the primary health care in universal health coverage. WHO, together with our partners for the GAP Accelerator 1, will continue to build and rebuild the primary health care to achieve universal health coverage via the technical cooperation, capacity building, and experience sharing. Thank you, primary health care team, for the 2020 achievement, and highly appreciate the support from the special programs on primary health care in headquarters. And Happy New Year for all the participants in this webinar. To improve ourselves in the future webinar, please share your feedback on the webinar evaluation With this, we are reached to the end of the PHC for UHC webinar for the 2020. Thank you for you all. Thanks a lot.